Welcome to the 10th Annual Johns Hopkins Critical Care Rehabilitation Conference Pediatric Patient and Family Interview. Today, we're going to meet little Les and his parents, Cameron and Amanda. Les spent 4 months in the Pediatric Intensive Care Unit. He was born December 2018, had multiple cardiac surgeries, as well as an emergent cath lab intervention and recurrent necrotizing enterocolitis. A long journey in the hospital before he was able to go home and be with his mom and dad, and now, most recently, his new baby brother. At the end of this interview, there'll be an opportunity to ask questions in our live Q&A with Les, Cameron, and Amanda. So stay tuned. So with no further ado, I'd like to introduce you to Cameron. Say hi, Cameron.
Hello.
Amanda.
Hi.
And most importantly, Les. Hi, Les. How's it going, buddy?
I saw the green lawnmower.
Green
Yes,
lawnmower,
we
yeah.
have a green lawnmower, and our neighbor has a green lawnmower.
Wow, very cool.
And Daddy prepares a red lawnmower because it had a little center up on it.
And Les, how old are you? How old are you? Can you show me fingers?
Not one,
Mm.
two.
2 years old. Very
Come
cool.
on.
Les came to us as a newborn, right? So tell me about life for Amanda and Cameron before that.
Yeah, so we had actually just moved to Nebraska from Nebraska like a year and a half before he was born.
Okay.
So I could complete my predoctoral internship here at Kennedy and Hopkins.
Okay.
And then we decided we were going to stay so I could do my fellowship here. And we were just moving out to Odenton. And we had gotten our anatomy scan, but they couldn't see his heart really well.
Okay.
So we went to Nebraska, and I actually had my graduation. A week later, we came back and had a fetal echo specifically. And we're told that there was something wrong with his heart pretty significantly. And I think it was just pretty obvious that there was a ventricle missing. After that I feel like things kind of changed for us. We had tried for a really long time to have kids and hadn't been successful. And then I miscarried right before we got pregnant with Les. And so we were just like so excited. But after that, it felt hard to be so excited because we didn't even, know if he was going to live. There was a lot more, I think, some like grieving that we already had to go through as parents.
Right.
We're not yet like actual parents yet.
Right. So tell us about the day Les was born.
So I was induced, but at 39 weeks, but he actually didn't come until the day after. And I'd fully progressed, but he was stubborn then, just like he is now, and kept flipping over, and even with manual rotation. So I had to have a cesarean before he was whisked away to the NICU.
I don't know. Hard to describe this first kid, just
Right.
the emotions and everything. So
Of course.
it was nice to see him, and I was excited for him to actually get to see his mom, and excited to hold him. It was difficult to figure out can I hold him? Can I not? Because all the emotions and hospital and all that. Just trying to
I was
figure
about
out.
to say all the typical first time parent holding that small of a baby for the first time. But plus they'd already put in a line to be infusing prostaglandin to keep his PFO open. So it was just sort of an additional can I layer of fragility, and am I allowed to pick up my own child sort of thing. And then later that night I was able to go down and actually be sitting up, and I did get to hold him, which was really nice.
We call it #therapeutic cuddles, but one thing that parents always tell us is often they don't know that it's okay to ask to hold their child, and that's all you want to do as parents, let alone first-time parents. So I'm so glad that you got to hold him. Let's talk about the pediatric intensive care units. Obviously, it's a very unique and somewhat chaotic environment. You're first-time parents, you have a brand new baby with congenital heart disease, you're in the peds ICU. What are those first few days like, and what are the emotions? I mean, just talk to me. Tell me about that.
The first couple of days it was just sort of like getting used to the atmosphere, I think, of the PICU, and like beeps all the time and things being
Yeah.
loud and tons of people in and out all the time, like
Right.
numbers on screens that you don't quite know what they mean yet. And no one has like really told you what they mean.
Exactly.
You're like, is this all good? Or like something beeps off and someone doesn't, like looking at the nurses to see, are they concerned? So there was like the first couple days there where we were just really enjoying like holding him, getting to spend some time with him. And then the third day is when he had his first open heart surgery. I feel like I don't remember that morning. It was like scary to think about sending him to the OR, but we also, I think, we were naive to what things would actually look like when he came back. But yeah, so then he came back and it's just like, he was really puffy. And obviously he has like the bandages on his chest, and there's like, we were like worried about a line before, right? And then he's covered in lines, and they're like 3 different poles with multiple pumps on them and things beeping off all the time. The nurse was basically like all the time doing something, checking something on him. Like, it was just like, okay, whoa, you get the phone call in the middle of the night from a number that you don't recognize. That's like consistently one of the worst things. Anytime that would happen. And it happened a few times for us. So, and I get down there and the doors have been pushed back on his room, and it felt like thousands of people all around my son, who was tiny, right? Like, and he has all these wires, and everyone's talking and looking at monitors and looking serious, not happy, like the smiles and reassuring. And they were actually changing his room into an operating room to hook him up to ECMO if things didn't change within like the next few minutes, essentially. With where we were at. And I just couldn't even talk. Like, I'm just like, how is this happening to my son, who I've only known for 2 days? But Les pulled through without needing ECMO at all, which is like a miracle. And we're extremely glad. Of course, if he needed ECMO, he needed it.
So you mentioned briefly your background, Amanda. So why don't you tell us a little bit more about that, and then kind of how that impacted how you viewed this ICU stay over time, and then we'll get to Cameron and ask him about his perspective on that.
So I'm a child psychologist by training, and I was actually trained as a school psychologist. So coming from that background, school psychologists work heavily in teams with speech language pathologists, occupational therapists, physical therapists. Like, so I was already coming with training of like a team view of, making everything work for a kid in terms of collecting all the data and really understanding this kid and what they needed to be successful. And so that was more of the background that I was coming from. Plus, one of my areas of like research specialization was family school partnerships. So bringing families into that fold, not only professionals, but families who have all the expertise on who their kid is, even if they can't tell you this is how far delayed they are with something, or something that they excel at, like on paper. So because that was more of my training, once I wish that we'd known like what rounds were and that they were going to happen every day and things like that. But once I like figured out that this thing was happening, like, and what rounds kind of were, I made it a point that every day that I was going to be there for rounds. And if I couldn't be there because it happened to come by too late and I had to be at work later, that they would call me, and I would have whoever was there, whether it was Cameron or my mom or his mom, to be there with Les to be at rounds. And they could ask specific questions for me, or they would hear information and they would tell me what they heard. And then if I had questions, whenever I was called by like the nurse practitioner or the fellow to be updated on how rounds went, I could have some questions.
Tell me about when Les, obviously Les was sedated and intubated in our unit for a long time. That was a significant part of his course. What was that like for you both? Seeing him sedated, because often he needed to be very deeply sedated, And also, did you have questions about him developing as a normal baby? You know, all the questions that go through your mind. What were you thinking?
So I think like initially when he was intubated after he had his shunt placed, it was like understandable that he needed to be intubated. And I think just in general, we had a lot of concerns because he had required resuscitation. We didn't have a pre-op MRI.
Okay.
And we didn't have a post-op MRI. All we were able to have was an ultrasound of his brain that had been done prior to, and then again
Right.
afterward, which is pretty standard. So we didn't see a brain bleed or anything that looked like massively different. So that was sort of
Right.
reassuring. And then from my own professional expertise, knowing that like neuroplasticity being at its greatest, I felt, I think, more reassured. I don't know. I feel like I wasn't as worried about him being intubated. And then it seemed like after that first surgery, he was doing really well.
Yeah.
We had actually been moved up to the floor, and everyone was just amazed because he was like taking from a bottle
Yeah.
consistently and really well, and his sats were in goal. And after he was extubated, it was just basically like never look back.
Right.
Up on the floor, and he was up on the floor or the step down unit for less than a day before he had to be reintubated in the PICU again.
Oh.
So the decision was made, you know, the night that you were on, to take him to the cath lab and do a cath procedure. And then while he was down there, he just continued to deteriorate, and they actually asked you to bring ECMO equipment to the cath lab.
Right.
Because they didn't even think that he was going to make it out of the cath lab, prepared to hook him up to ECMO. And he didn't need it again. Like he somehow slowly like turned it around.
And back to your point of like, how does intubation make you feel and all that stuff? It's just like just seeing your child with something in their face and in the way, and like also on the medication, making them drowsy just when they were already interacting and whatever, and they're no longer interacting with you, and you're just confused. And
well, and then just like to have pictures from literally the day before where he just looked like a normal wide-eyed baby.
Yeah.
Like every time I look at that picture, I feel like he's like looking directly at me, like, why weren't you there when this was happening? And of course it wouldn't have mattered if we were there.
Right,
like what could we have done for him at that point?
Right.
But then the very next pictures we have where he's intubated, he's just like a balloon.
Yeah.
Extremely puffy. And just to watch, like he had to be completely out of it for a while because his body was just like shutting down basically. So it was like, we can't even let him do any work to like be awake right now.
Right.
Like people putting Vaseline on his eyes so they don't dry out, and he's not moving at all. And people, like the nurses, rotating him every so often, you know, from like side to side. So he's not just completely on his back and getting sores or things like that. That was really hard.
Mm-hmm.
It was nice though when he started to come out of the sedation. He was still intubated, and actually, I don't know if you're able to put the video in, but I sent it to you. And there's a video where he's sucking on his pacifier around the tube in his mouth, and he's like blinking slowly, and he still wasn't fooling himself, but he was more responsive, and it felt really good, even though it was hard to pick him up at that moment. So we didn't do it a lot because of all the equipment, but finding other ways to really try and like soothe him, like a lot of like touching his head and like stroking carefully and like stroking other parts of his body, or like holding like kind of tightly with some pressure, like if I was holding him in my arms, what that might feel like for him. Talking in a nice like low voice and things like that. So we found other ways to soothe him at that point, but that was hard. And then after the Glen, they want to extubate as soon as possible.
Right.
But of course, feisty, stubborn Les, one of our friends saw him pulling up out of the ER, going back to his room, and she was like, he is sitting up. He was just eating. He was like screaming through the ventilator and trying to sit up, and the chest tubes are there, and there's just like blood coming out. Well, because he wouldn't relax, he was losing too much blood, so they had to paralyze him for a day, and he had to be intubated for a whole other day. And I think that was particularly hardest because the other times we could still talk and love on him. But at that point, when he was intubated again, he was 3.5 months old and he knew my voice.
Yeah.
I couldn't talk while he was intubated because he would eat through the paralytic and they would have to redose
He heard you. He heard you. He knew you were there.
I had to be silent, like, and I couldn't touch him and I couldn't talk to him.
Just letting him know that you're there. I think that's something that we often forget to remind families, is even if you can't like hold them yet because of all the equipment and it's not safe yet to do so, just letting them know it makes such a difference.
Yeah, just let them see you, because that's kind of hard. And when they're sitting in their bed and you're sitting next to them, they're not looking towards you. But
I mean, it's not like they're looking over like, hey, Dad, how's it going? Yeah, you have to get up in their face to make sure they see you.
Yep.
And there are like so many other ways of caring. And I think that we had to figure some of those things out, like how to try and soothe him without picking him up.
Right.
And like to this day, he's not one that's too cuddly.
Yeah.
Right.
That's just because that would be who he is, or if he just didn't get that as much for the first few months, that we couldn't always do that. Or there were times where I had to help hold him still for a procedure.
Right.
Trying to place an IV or things like that. And I feel really bad because I felt like complicit in that, but all I could do was like talk to him and hold him firmly, but I was also trying to like rub so he like was soothed in some way. But you just try and do what you can, but it's a lot harder when you just want to like hold them and protect them from everything. And
of course
you can't, because if you did, they wouldn't get the help that they needed.
Well, so we're here at the ICU Rehab Conference. So let's talk a little bit about, and this is, you definitely have a unique perspective, Amanda, given your background, about rehabilitation, but also habilitation, right? So, you know, you have a baby who's actively, the neuroplasticity is amazing, but at the same time, they're supposed to be developing and doing all of the things that normal babies do. So when did PT, OT, SLP get involved in his care? And how was that interaction? Was it challenging given his back and forth ebb and flow of critical illness? Tell us a little bit about that experience.
I think we didn't have too much support from SLP because he wasn't taking anything orally. And every time they came by, they could see that he had a really strong suck because he loved his pacifiers.
Okay.
His Webinar pacifiers.
Yeah.
We had some OT and some PT, but I think one of the hardest things was that we never knew when they were coming.
Right.
And from pretty early, I had actually had Les on a pretty established like nap schedule. So I never knew when they were coming. And not, it seemed like when they did pop by, it would be during one of his naps. And I literally actually had a sign posted saying what time his nap times were. And I had it put in his chart. So it was like, please just don't come during those times. Right. Just the times that they were there, whatever they were able to show us, we would take and do as much as we could. And I think probably one of the biggest habilitative things that we actually did was when we asked, like, can I bring stuff in from our house? And it was like, yeah. But it was almost like a duh. Yeah, like, how did you not know? And I'm like, well, no one tells you. And
the fact that you knew to ask that, right? You can imagine there's a lot of parents who would not even ask, right? It wouldn't even occur to them to ask because it's not a natural question.
They say that. And then the next day, so I came home and I was like, Cameron, we need to take all his clothes up there, because as soon as I knew I could dress him, they were like, yeah, you can dress him. And I was like, okay, let's bring it in. So we had all the snap onesies, you know, in the world. So everything could like come out really easily. We brought in toys and books, and I brought in like play mats that we had at home. And we had music in there that was given to us by Child Life. So we always had music on for him.
Sound machine. Sound machine is like required in the PICU.
Yes, there was a lot for him to look at. We made sure that every day, at least once, like unless it was during the times that he was intubated, that he was getting out of the bed.
Yes.
And he was, every day he got at least one walk around the PICU, and he would get out of the bed to like sit on the lap and read with us, or to go sit in his swing. He loved sitting in his swing. I would sit him up to be able to look out in the hallway and see different people walk past, and people would then interact with him, because it's not every room that you see a little smiling baby checking you out in the hallway, right? So he got
And
a more
it's so good
interaction.
for the staff too. I mean, it boosts morale for everybody. And I know you know this. Les was our pick you up poster child. I wanted to make sure we talked about his first walk outside. So tell us about that. I got to be witness to it, so that was very exciting.
Yes, I was about to say you got to come for part of the walk, but that was really exciting. I remember just in general after his first walk in the PICU, like his eyes were just like, like peeled the whole time, and it was the same thing outside. And it was a windy day and it was kind of chilly when we went outside, so we had him like piled up under blankets. I think we have a picture of it, and he had a hat on, and basically all you see is just a little face peeking through. And he was super gassy after that because I think he caught a lot of wind. But we could always like gauge the interest, right, by his sucking, because he would suck harder when he was like really interested in something when he was that little.
Right.
So that was really exciting. As he got bigger and it was a little warmer, we would take him out, but then we'd also pick him up and carry him like on our hip a little bit, a few steps, and take him over to like a tree and touch a leaf. Or like touch a bush and touch the leaves on the bush and things like that. So going outside was like really, really nice. And I remember, when you're planning in your mind for what you want for your baby, I was like, I'm going to take a walk every day when I'm on maternity leave, and he'll get out. Maybe I'll do it twice a day. It'll be really great.
Right.
I had bought stuff for the stroller to go out because it was going to be winter when he was born, and we didn't get to do that. And he didn't get outside for a couple of months, but once he did, that was something we consistently asked for on the weekends because Cameron would be able to be there. And so those were like our family excursions.
There's one topic I need to make sure we talk about, and that is babies and delirium. So, but you know that Les had delirium at some point during his hospital stay. So how did you know, and what did you do?
So it was after the Glen. When he was extubated, he was intubated longer than they usually like to, but it was basically just an extra day. He was extubated, and over the next like day or two when I was there, I was noticing like it seems like he's not sleeping, like he looked really sunken in, and I was just noticing, I was like, it seems like he's not sleeping. Like even when I'm holding him, and he didn't need to be held to fall asleep, but I would do that sometimes, but he wasn't sleeping in the bed, and it seemed like everything was waking him up, and that was not usual.
Okay.
And I would hold him, and it's like he would fall asleep, but then he'd jolt awake again and be like looking just like around, and his eyes would kind of like glaze over, and he wasn't focusing on things. And so I brought it up at rounds after like noticing this for a day and a half, and I'm like, something's not right. Like he's literally not sleeping at all, even when we turn down the lights and I'm holding him the way that he likes to be held when he's not feeling good. Like something's not right. The longest I've held him and had him sleep was 20 minutes.
Wow.
No way he's getting rested. She actually prescribed melatonin for him. We gave it at night, and he slept like that night for longer. And then
huge.
He looked better already. Like he didn't have the bags under his eyes anymore. He was able to focus. He was more interactive again versus just kind of sitting there being like, I just don't feel good.
So what you're describing is classic hypoactive delirium. And the reason that we don't recognize it a lot, unless we listen to a parent who says something's not right, is because those patients are not challenging. In fact, sometimes they're the easiest patients because they're just laying there. But what you described was inattention, which is a hallmark diagnostic criteria for delirium. So it's so important that we make sure families know to tell us if something's not right. Like we need to know, because you know them best. Cameron, tell us about, finally, the day of discharge comes. You get there, right? You're going to go home with your son. So tell us about what the first few days were like. Were they scary? Were you ready? Did you feel prepared?
Yeah, I mean, it was scary because you're like, but he's not going to be hooked up to any machines anymore. I can't see the numbers. Is he going to be okay without the oxygen sensor? Or?
What do we do without the numbers?
Yeah, exactly. Like I was used to staring at the screen sometimes when I was concerned about him being like, oh no, he's fine. He's saturating properly. Okay. But then like, that was scary. And then as well, like just being like, okay, he's coming home. So what now?
So tell me about any sort of PT, OT, SLP needs after he left the hospital, and how have you navigated that?
So after we left the hospital, I think he actually was only like 2 or 3 weeks delayed with his PT.
Amazing. Yeah.
And that was it. So PT and OT stayed on for like 6 weeks. And I had initially, as soon as we left, called infants and toddlers, to place a referral to be evaluated, but I ended up canceling that. And the OT and the PT were supportive of it ultimately. Although initially there was some hesitation from one of them, like, well, he qualifies for it, so why wouldn't you get it? But I guess for myself, like I'm thinking I don't want to overburden a system where there are kids who legitimately need these supports, and like he's doing well.
Right.
We saw SLP like once.
Yeah.
But basically the OT actually helped us. He learned to drink from a straw by like 7 months old.
Wonderful. Wow.
He had a really strong suck, but it was like too strong.
As we learned in the PICU too, right? Yeah.
So he'd shoot himself in the back of the throat and then like choke. And so that wasn't going to be a viable way to get him
right
the nutrition that he needed. So we started using the honey bears, and she just provided some basic guidance, and he like took off with that. He still uses those bears to this day. He likes drinking out of them. He also drinks out of a cup, like amazingly. And then we actually just did a really brief course of treatment with an occupational therapist because he was having a lot of gagging. Well, it turned out he had only like learned really to chew enough on his left side. And so he would get fatigued, wouldn't chew enough, it'd get stuck, he'd throw up. So,
wow.
But basically he just needed like 3 or 4 sessions, and he now chews on both sides just fine. We still get his neurodevelopmental evaluations done once a year is all they need to see him, because he's doing well. He's actually advanced in like his language and some of his cognitive skills.
We could talk forever, but unfortunately we have limited time. I think the closing message that I'd love to hear from both of you is, we have an audience of interprofessional team members who have committed their careers and their lives to making sure that critically ill patients thrive, not only within the ICU environment, but also after they leave, and post-intensive care syndrome is something we talk about a lot, and it impacts adults and kids. So we've talked about a lot of different things today. What is your take-home message for these physicians, nurses, PTs, OTs, SLPs? What is the most important thing that they can do for patients and families as they tackle this most stressful and difficult time in their lives? The big question.
Sure. I'll go first. So probably just know that they're people and they're smart, and try to communicate with them and get them to understand what's going on in the situation. And also it was difficult to have like the people that are in rounds change all the time, and trying to create rapport with people and trying to have an understanding of, okay, I know who this person is and I trust this person, and getting all the information from them. So maybe just more like creating relationships with the family members, and creating like a trust bond almost, like, and
because the rotation has to happen, like obviously logistically.
Sure.
Similarly, I think one thing is really seeing the family and the child as people. I think that's one of my biggest things, because like I know when you're rounding, all you have in front of you are these numbers, right? About like, what is the hemoglobin level? What were the SATs at? What were our numbers?
A lot of data.
Yeah, it's all data. And yes, that's important. And I deal with data all the time. So like, I get it, right? But sometimes data can obscure the reality of the family and the person in front of you.
And it sounds like that goes across the board, not just in the day-to-day medical care, but on the, in the rehabilitation journey, all of the interactions you have with any medical professional. The key is listen to the family, because they know their child, they know their relative, they know their family member. Wow. Well, I just I just want to say thank you, thank you, thank you to both of you for sharing your incredible perspective with all of us. I know that we all learned so much, and we're overwhelmed with gratitude to both of you for sharing, and to Les, who's now in bed, but please give him a big thank you hug for us in the morning. And we're going to get to Q&A momentarily. So thank you again very much. We'll talk to you soon.
Sounds good. Thank you.
Thanks.
Thanks. All right. Good morning, good afternoon, and good evening, wherever you are, to everyone. And first of all, thank you so much to Amanda, Cameron, and Les. Les, can you say hi to everybody out there?
Bye.
Hi, buddy. How's it going? It's so good to see you. I am just so thrilled to have you here for our live Q&A, and I know everyone in the audience is as well. And so we are just going to jump right in, if that's okay, and start asking you some questions to hear from your perspective, which is, I think, the best part of the conference. What's that, Les?
What?
I made a boat.
You have to talk louder.
A boat.
Oh, you have a boat today. Oh, I love it. Very cool. Dr. Stapa is very impressed. Okay. So there's a comment from Mark Hudson, who says, I was an adult when I was in the ICU, and I know I felt alone at sea when I was discharged from the hospital.
Drive this boat.
I see you mentioned the fear leaving the hospital too. How can we help to reduce this anxiety and stress on the patient and loved ones when you get discharged?
Sorry.
That's okay.
I think it was nice before we left the hospital that people had spoken with us about like how to use the feeding tube and things like that. Obviously, basic needs sort of things. And we'd also spoken with our cardiologist about some of the, basics of like monitoring his oxygen, what things we should be concerned about. But it was kind of like when we got home, I think we'd done so much with him in the ICU that we felt confident in being able to like move him around and be active with him in our house. But I can imagine that if he'd had any other sort of constraints, it might have been helpful to have like a home visit beforehand to see if there was anything we could do to make our home, work better for him. Absolutely. If he had more needs. But I think in general, we kind of set it up pretty well. But
yeah,
is there anything you think would have been helpful to have?
You talked about the running of the food.
Yeah.
Okay.
So they taught us how to do that. I think that was one of our biggest concerns using that, since that was like the only way that he was getting nutrition at that
point. The feeding pump. Yeah, absolutely.
Bless you.
Can I go play?
Yes.
Yes, Les, you can go play. Thank you for having a presence for a few minutes. We appreciate it. Yes. I think what Mark is highlighting and what I hear you saying, and Cameron, you can say if this is correct, is that it always helps to start early with regards to setting expectations of like what is coming in the future. And although we can't predict how things are going to go, starting early with talking about it so you have time to prepare, I think is really important. Well, there's a lot of questions coming in, so I'm going to jump right into the next one.
Okay.
Maria asks, how often would the family like communication from the PT? And Maria, I'm not sure if you're referring to as an inpatient or once you leave, but in general, how often would you like to hear from the PT on both sides?
I think it would have been nice to hear more, maybe like weekly or something from the PT, because I feel like while we were in the ICU, and granted he wasn't, significantly delayed, we were doing a nice job of keeping him on target, I feel, but it seemed really sporadic when the PT would come. Like we never knew when they were coming, and so that made it hard to try to be there and communicate goals or things like that. And so we didn't actually know. I just knew from my own like understanding of child development that he was generally on target for things. But that's not ever actually a conversation we had. So I do think more regular communication with those providers would have been nice. Like,
or even like a schedule of when they're going to be there so we can come and learn the strategies that they're trying to teach.
I really loved that when we went home, our PT was very communicative, and Cameron and I weren't always available when she came, but we had like my mom or my mother-in-law there, and she encouraged them to take videos and we'll walk them through the steps of things while she was there. And she left a report with them and little notes and things like that. And I found that really, really helpful.
Awesome. No, I think that's incredible advice. And I think that kind of answers Bridget's question, who said, how can PTs, OTs, SLPs be more helpful to families during the acute ICU phase? So what I hear you saying is the communication piece and the timing of visits.
Yeah.
Okay, great. Rachel Santiago, who's an SLP, said, you mentioned being unaware that you could bring familiar and personal items from the home during your ICU stay. We're about to launch an activity menu for families in our PICU for this reason, and to encourage families to engage in the habilitation, which is critically important since Les spent many of his formative months in our ICU of their children in this challenging environment. What are some other things you wish you knew you could do to achieve that?
I think the biggest one was like bringing things in, or even to be able to ask, like initially it was like, can I get him out of bed?
Yeah.
And once we realized that we could get him out of bed, especially it was, of course, when he was intubated, we were more careful to make sure there was a nurse in there. But like once they showed us how to do everything, then we could get our kid out of bed whenever we wanted. But we didn't know that we could do that because it's not like someone comes in and is like, hey, you know, your kid, yes, is critically ill, but like they can get out of bed and do stuff, you know.
Or like you can dress them in your own clothes or in their own clothes, or like bring in items that help them to get familiar with something that's outside the hospital.
Because I think when you think about people being sick in the hospital, you think about being like bedridden and always in a hospital gown and things like that. And that doesn't have to be the experience, but I don't know that that information is more widely disseminated to families. So I think maybe even having a list of like, if it's an anticipated hospital, say like, did you know these are things you could bring from home?
Yeah.
These are
Right.
things we have that you have access to, and please feel free to ask for that. You can get your kid out of bed. Like, ask a nurse how to help.
Right.
Because like I said, like Les was hardly ever in his bed laying still. Like once we knew, he was like everywhere. Sometimes they'd come in and be like, where's Les? They'd look in the bed. The first thing, still doctors and nurses would look in the bed, and he was hardly ever there. And so sometimes newer doctors or nurses who hadn't been with him before would freak out for a second, but those who knew that he was just not usually in bed were able to bop in and be like, all right, I got to look on the floor first, or over in the chair on the couch or something, because he's just kind of getting out and about.
I love that. I want to underline that because we talk about therapeutic cuddles a lot in the PICU, because so many of our patients are infants, and often that's the most that you can do mobilization wise at some points. And I know as a medical team, we often do not mention on rounds, oh, have we talked about you holding your baby? Like, and as a parent, that's the one thing you want to do. So, and we talked about that a bit in the interview, but I appreciate you underlining that. I hope we all think about that much more. All right, the questions are pouring in, so I'm going to keep going. Dana Lott says, in the hospital, how best can providers, therapists, staff educate parents and caregivers on the things like how often therapy happens, especially because the teams change every week, what the beeps could be from the monitor, handouts in a folder orally or at the beginning of the stay, posting things in the room. I think you've started tackling that a little bit, but this is obviously something people are very interested in.
Yeah, I think just thinking about how people learn and just what certain, you know, sometimes you may be ready to digest or not. Like if I'd been given a folder, I could have read some of those things ahead of time. But I also think, you know, if it's handed off in, you know, rounds or even nursing staff changes or things like that, that, you know, this family is like, this is their first day.
Right.
You're going to need more psychoed about what this is, because you know what you're doing and this is your job, but they don't know. And these things may not be overt to them. And sometimes if a machine keeps alarming off, like a family is at like a constant stress level, and they may not even know to ask, like, can we change the limits? Because we know that my kid's a little bit low, but like on his oxygen right now, but like, does it need to keep alarming every second?
Right.
Because we know that's where it's at. We're watching it. Can we set the limits lower? Because you're still doing your checks. I'm still watching those numbers. You know, things like that.
It was nice to have like they have a board up there that was a whiteboard that they could write specific details on, like
Yeah, the
these are
goals.
the okay goals for oxygens. And eventually someone explained that to us and we were like, oh, okay, so
Right.
where is it beeping and is it between the goals? Okay, we're fine. And that was kind of one of those things that was nice to be able to look at and be like, okay, this is a good, we're fine here, even though it's beeping, basically.
Yeah, like we're okay, but this is something we can note and we can bring it up at rounds if we
Yeah.
notice a trend in the data.
Right.
Um, because there were sometimes, you know, the nurses come in and get their data at the correct intervals of time, but there may have been fluctuations that I was noticing kind of throughout the, you know, 4 hour period, or even every, you know, 6 to 8 hours, if that's how often they were just having to document depending on where he was. And sometimes the number at that exact moment wasn't necessarily representative of the past few hours. So I was able to
Right.
share that. And in some cases it was like, okay, if we're seeing this trend, we know that for Les, that means that he might need a blood transfusion and we're probably going to see his sats drop soon. And that would happen like clockwork. So it was really empowering to feel like I knew what those numbers were. I understood what people were saying at rounds. So having like a sheet and the specific goals for my kid written down, and then having nurses who could also, you know, share that information, because I think that also opens the door for families who are like, is it okay to ask these questions? I don't want to sound dumb.
Right.
Right? Like I'm a pretty educated person, but I'm not a doctor and I'm not a nurse, so I probably don't know what these things are, but people might not feel comfortable asking that because if you're just kind of doing your job, they might not want to interrupt.
Well, you bring up a very interesting point, which we don't think about a lot, is the learning curve, right? And so we talk about trainees, you're a medical student or a resident, and you all eventually learned like there's different levels of training among the physicians, et cetera. And we talk about how we teach based on the level of training. You guys went the full gamut from having zero knowledge of an intensive care unit environment and what that entails and what that means for your child, and also being new parents, to being experts, in the, and so having knowledge from our perspective of where you are on that learning curve also, and how much you have to contribute with regards to what's happening with your child, which starts on day zero, I think is incredibly important. So thank you for highlighting that. I think Mark has a really important question. Do you think having the assistance of an ICU psychologist might be helpful, not just help with stress and mental health, but also to act as a bridge with the care team?
As a psychologist myself,
That was a bit of a loaded question, huh?
that would be fabulous. When I left, I was feeling like there was a gap that could be filled by someone with my training, for example. A child psychologist, I happen to work quite a bit with families because of the age of children that I see. So I'm primarily working with families to influence change in kids. And I was like, I would have like the perfect skill set of like how to help support, you know, families in this position, or there are many with my training who could help navigate this, not only the stresses of being sick, but also like parenting under these unique circumstances, and how your parenting might change, or like supporting development and your kids' mental health. Because I know even going in for our basic checkups now, like there are a ton of kids who have very significant behaviors when they're getting like an echo done,
Right.
much less other procedures. And sometimes, you know, obviously there are a lot of other things that happen in the PICU, and we need families to feel supported and kids to feel supported, and to have parents know that they have some strategies to help support their kid. So I really feel like a psychologist would be pretty fabulous in the PICU.
Mhm.
But
I love that.
Yeah.
That's a great suggestion. Okay, well, that feeds right into Rebecca's question, Rebecca Nemick, who asks, were there any opportunities provided for you, both as parents in the PICU setting, to engage in self-care? So we talked about how a psychologist could be helpful, but how did we facilitate self-care in the hospital, if at all?
Oh, yeah. So there were a couple of awesome opportunities we got while we were there that were like a step away for a minute, get a breath. So like there was massages offered, which was nice. And then they had dinners and different things like that that you were invited to, which was nice to just go down and you could meet other families going through kind of the same situations. And also get a breath if you wanted to, just like sit and relax for a minute. And there
Right.
were also some other really cool opportunities that were given us, like if you were there over Thanksgiving or Christmas or something like that, that was kind of nice to have something that was made it feel like Christmas or Thanksgiving. So like at Christmas, they actually came and gave out tickets to say, when you get time, you can go upstairs and we have a gym with toys that you could pick one out for your kid. And that was like, felt special. Like it helped out with the, oh, it is Christmas and he should get something type thing. So
Mm-hmm.
things like
Wow.
that were really nice. Am I
Yeah.
missing anything that was good for you?
I think when we went on our like first, dinner out where there was not going to be anyone there with Les for a while, the nurses were all really, really supportive. I actually have a picture. They took him out in his stroller with his pole and everything, and he got to do like shift change with them, and everyone was so
That's
excited
great.
for us to get some time. So I thought that was supportive of like parents getting out. I do think there might need to be some more explicit encouragement of that, though. I think I was pretty cognizant of trying to do that, and we did make like we rarely slept at the PICU actually because it would not have been good for our self-care to be
Sure.
there all the time because it is so stressful. Even if it's not your own kid, like just the empathy for like other families and knowing
And all the noises.
all the noises
Yeah.
that are coming from their rooms or things like that that might not be good. So I think I emphasize that a lot for us.
Yeah, that helped.
But I know some other families that while we were there, I think could have benefited maybe from some more explicit support in self-care at that time, and they had to do a lot of work after.
Right.
And I
Right.
think all of us probably have work to do after
Mhm.
because this is not a normal experience.
Well,
Mm,
a lot of
things
parents
like that.
probably are like focused on their child, not themselves at that point. And
Exactly.
then once they're
So
out of the hospital, they're like, okay, how am I doing?
yeah, I think
Right.
those there were activities that were offered, but I don't know that anyone necessarily with me sat down and was like, so how are you doing with your self-care?
Yeah.
Mm-hmm.
What are you doing to take care of yourself, because you need to take care of yourself to take care of your child. So I don't know that maybe those conversations did happen for other people, but that wasn't explicitly something that was had with myself or Cameron.
Right. So what you're saying is having a focused effort to sit families down, and the question of timing, and also you guys were with us for a long time as opposed to a family that's been there for 2 days, but everyone's situation is different. Some had planned surgeries, others had sudden trauma. And I know as a physician, I think about that a lot. Like when do we intervene? And when is it too early to intervene because they're already just they just need to wrap their head around what's happening and try to wrap their head around it. So thank you for pointing that out. So there's 2 important questions that I want to tackle before we stop at 9:40 to get to the rest of the day. We know that every person learns differently. Neha Seth asks this question: how did each of you like family education material presented to you during the PICU stay and prior to discharge? Because I think one of the concerns we often have is that we can put a bunch of stuff in a folder or, online, but will it be accessible to everybody? So what would you suggest to try to tackle all families and have the most impact?
So I don't think we had access to anything online, but I feel like that may have changed in the time between us, like being in the PICU and
Right.
Like now. I know there was a folder that was given to us. I think if it had maybe been given and someone was able to kind of like sit down and review some of the things with us, and especially like I'm thinking even stuff that goes on top is what's most salient. So like
Right.
what the numbers might mean that you're seeing, that your child is always going to be hooked up to while they're in the PICU. And then maybe like a note space for your specific numbers if you want those. But I can certainly see how just handing a packet of information would be overwhelming. So I think the packet of information should be given for some people
Right.
who prefer a reading format or for revisiting later as a refresher. But I think having someone, review verbally with you.
Yeah. And probably
in the
not like
beginning.
the first day, but
I think
after, well, I guess it
there
depends on the
might be
person,
some
right?
things the first day that would be like, this
Yeah.
is going to be important for us to know. These are what these terms mean.
Yeah, so
And
maybe
then
split it
after
up.
that, yeah, like not all at once, because
All,
I think
yeah. Here's this binder of things to read in the
Right,
midst of
like,
the
here's your
acute stress you're
homework.
dealing with. Right.
I'm thinking especially for families who are there because of a sudden trauma. Like this is
Of course.
unexpected anyway, completely out of the ordinary, and just literally cannot take it all in at that moment. So prioritizing like what's the most critical thing for this family to know and understand at the moment, and what information do they need me to review with them, and then what can be saved until tomorrow when they may be more available for processing this important information. And families who know like ahead of time, like it would have been fabulous if I had some of that stuff ahead of time, because I read all the pamphlets like multiple times before we went in.
Right. Right.
So that would have been nice to have ahead of time if we knew that it was going to happen, at least that we would be in the PICU for a time.
You can even just ask if they would like to continue with the information, or is this a good stopping point, basically.
Yeah. Like
I love that. Thank you.
Mhm.
So last question before we break, and we could go on for hours, I'm sure. So thank you so much for sharing with us all these perspectives and your answers to these very important questions. Khalid asks, at any time, have you ever had thoughts that you would rather spare him all the suffering, surgeries, and tubes? I'm asking because in certain areas in the world, the resources are not available to do all of these amazing things. And we discuss such possibilities with parents. We can never really know how parents feel in these situations. That's a big, tough question.
Yeah, I think we had those thoughts initially when we were given the diagnosis, because we got that very early in pregnancy, like still.
Halfway through.
Yeah, but like for us, that was never something we really wanted to do, because we've wanted a child for a long time. So
I think ahead of time, yeah, we were like, we're on this, we've got it. But I would be lying if I said that there weren't moments where it felt so hard that I was like, I felt really selfish to bring him into the world knowing that he would have had to go through some of these things. And, clearly he's amazing and doing really well.
Yes.
But there were some days where it was just like, he shouldn't have to go through this, and it was my fault. So I think there certainly is some of that for families who are choosing to bring their child into this world knowing that some things are going to happen.
Yeah.
I think for us, because it ended up being drawn out so much, it felt even harder. Like we signed up for one thing and we didn't even know about some like neck.
That's true. Yeah.
No one talked to us about that ahead of time as even an option or some sort of like negative sequelae of the situation. And then here we are, and now so I think there were definitely times and that happened, but for the most part, we made the decision, and he's really happy. Like he loves his life. He's not miserable in any way.
It helped that he was very smiley even in the hospital, for sure.
Yeah, well, I think that's the perfect way for us to end. Les is an incredible little guy, and we're so honored to have you here to share your heart and talk to us about this journey that you've had with him, and also share who he is today. And we just, in that brief moment, I think everyone figured out who Les is. He is a vibrant little guy who we're just so lucky to learn from, and to learn from both of you. So if you were in our live audience, if we were all together, thanks to COVID, but if we were all together in an auditorium today, you would be receiving a standing ovation, no question. Thank you so much for sharing everything that you have, and for being with us. Thank you so much. I'll do the round of applause here on behalf of everyone. And then I'm going, sorry, go ahead, Amanda.
I was just saying thank you for letting us share. I think it's therapeutic in a lot of ways for us to share about our experience. And if it helps other families, then we're more than happy to do that.
Thank you so much. Thanks, Amanda and Cameron. And I'm going to quickly give some announcements and let everyone move to their next session. So first of all, there's a networking session for PTs that is starting immediately after we finish here. And that started technically at 9:40. So please jump over there for all the PTs. That's moderated by Danny Ludwig. Secondly, we have an 11:30 poster session coming up. Make sure you vote for your favorite posters. The voting link is available in the PDF that includes the images of all the posters. So please do check that out and vote. For my PEDS track attendees, you're going to join myself and Hallie Lenker in the PEDS main track. And so the adult colleagues are going to stay here. The PEDS folks are going to log off, and you're going to come over to what it says for session 2 in the PDF for the live webinars. So if any issues, feel free to contact the help desk, but come over to the Peds side. So you need to leave this session. And then remember, don't miss out on the virtual exhibitor hall, ICURehabNetwork.org. Complete the game card so you can win a chance to attend the conference for free next year. And then, of course, don't forget to tweet about your experience using hashtag ICU Rehab. Thank you all so much, and we'll see you in the next sessions.